Buenas noches para todos, bienvenidos a una nueva cápsula de Soy Pediatría Bosque. En la noche de hoy tenemos como invitada a la doctora Katherine Lord. Ella es endocrinóloga pediatra en The Children's Hospital of Philadelphia y nos va a hablar acerca de hipoglicemia. Bienvenida, doctora.
Well, thank you so much for inviting me to this talk. Really appreciate the chance to be here, with the focus being on hypoglycemia in children, hopefully trying to address maybe some of the more common questions that come up around kids presenting with hypoglycemia. So these are my objectives. First, to understand which children require evaluation for a disorder of hypoglycemia. Second, I'm hoping I can describe the differential diagnosis of children that present with hypoglycemia, and then understand why we do these, or why we're recommending sometimes these crazy fasting evaluations, these fasting tests. Just briefly, I was going to do two cases. These are probably going to seem very familiar to you because especially if you're in the emergency department at all, I'm sure you see kids that present with this quite frequently. So the first being a 3-year-old girl with 3 days of vomiting, diarrhea. Parents report not eating very much, and they bring her into the emergency department because she's lethargic. And noting the lethargy, they very quickly check a blood sugar on her. Her blood sugar is 56, with ketones of 4.1, so low sugars and high ketones. She gets a D10 bolus. Her sugar comes up, but she's not able to PO, and so they place her on dextrose-containing fluids and admit her for observation. Our second case is actually very similar. It's a 10-month-old girl with some URI symptoms, some slightly decreased PO intake, but who also has lethargy, and so her parents bring her into the emergency department. And on arrival, surprisingly, she has very similar blood sugar and ketone levels. She gets a dextrose bolus. She is also not willing to eat, and so gets placed on dextrose-containing fluids and gets admitted for observation. And I'll come back to these at the end of the talk, with sort of what our recommendations would be for these two somewhat similar but yet different patients. So hypoglycemia. If you open a textbook, the textbook definition of hypoglycemia is a blood sugar that's low enough to cause signs and symptoms of brain dysfunction, which sounds very nice and neat. But what everyone wants to know is what is the blood sugar, what's the actual number that is hypoglycemia. And as I probably don't need to tell you, that actual numerical definition of hypoglycemia is definitely controversial for kind of various reasons. And I'm going to talk a little bit about why we use the blood sugar threshold that we do here in the CHOP endocrine world. What I don't think is controversial is that we know that there can be consequences of hypoglycemia and that they can be very severe, particularly on a developing brain. So if the blood sugar is low enough, there's the risk of altered mental status, seizures, brain damage, long-term, this risk for developmental delay. And then it can actually cause death. Every few years, we will have a baby where the diagnosis of a persistent hypoglycemic disorder has been missed, and sadly they've passed away from the consequences. And it is well known that, as I said, that children and adults with hypoglycemia do have this risk of neurologic deficits. I put in bold here, there's multiple studies done in the hyperinsulinism population showing that anywhere from 1/4 to 50% of individuals will have neurologic deficits. And so that's why we feel so passionately in in the endocrine world about trying to identify these patients in a timely manner and put them on appropriate treatment if they have a persistent hypoglycemic disorder, to avoid those neurologic consequences, or if they don't have a persistent disorder, to rapidly treat the hypoglycemia so they're not exposed, so children are not exposed to low blood sugars for a long enough period of time that could put them at risk of brain damage. So why do we say from our from CHOP endocrine, that we're defining hypoglycemia as less than 70? So there's really quite good data that shows that the normal blood sugar range is 70 to 120. And this is based off of sort of multiple studies, one being what is known as the GLOW study, Glucose and Well Baby study, where they had over 70 healthy newborns with 5 days of blood sugar data, both point of care sugars as well as CGM data. And they did observe the transitional hypoglycemia that is seen in healthy babies during the first 48 to 72 hours of life. But by day 4 to 5, the average blood sugar was 85 with a standard deviation of 13. Additionally, there's good data showing that you start to get a counter-regulatory hormone response. So increases in cortisol, epinephrine, glucagon when the blood sugars get into the mid-60s, strongly suggesting that the body is trying to get the blood sugar back above 70. And then there's quite a bit of CGM data that shows children and adults spend the majority of their time with their blood sugars above 70. So that's why we define blood sugars, hypoglycemia, as less than 70. That's not to say that you necessarily have significant consequences or every single child needs a workup if their blood sugar is less than 70, but where we start getting concerned and where we think about if a child could have a persistent blood sugar disorder or requires a workup. Conversely, you could also think about what is the benefit then of keeping the blood sugars above 70? And I mean, hopefully it's obvious that our goal is to reduce the risk of brain damage. This just shows the body's response and the neurologic consequences that can start to occur at different blood sugar ranges. So as I mentioned, you pretty quickly, once the blood sugar is less than 70, start to see your counter-regulatory response. You don't usually get significant symptoms until the blood sugar's in the 60s, actually more into the 50s. And then really the risk of significant brain dysfunction and seizures come when the blood sugar is less than 50. So we also feel if you're aiming to keep the blood sugars above 70, you have a nice buffer before you really fall into that danger zone of blood sugars less than 50. So as I said, the reason we want to work up kids that present with hypoglycemia is to understand, is there a persistent hypoglycemia disorder there? Will they require treatment? These are luckily rare disorders. I put the incidence of the most common or some of the more common of the hypoglycemia disorders, the ones that we also have data on, which we don't have a ton of data. And you can see the incidence here. So these are not particularly common. And the glycogen storage disorders, this incidence of 1 to 25,000 encompasses all of the glycogen storage disorders, and not all of them cause hypoglycemia. So these are rare. What also makes it challenging is that the differential is quite broad, as I'll show you. There's a lot that potentially can go wrong in the body that can cause low blood sugar. So you're sorting through a pretty long list of diagnoses when a child presents with hypoglycemia. And then, as you know, hypoglycemia when children are sick is not uncommon. It's something we commonly see, though, as I'm going to show you some data, it's probably not quite as common as we as we think. So there's not a ton of data on on hypoglycemia in the setting of acute illness. But there are two relatively recent studies looking at the incidence of hypoglycemia in children presenting to emergency departments out of both Cook's Children and then the University of Alabama. And in both of these studies, they just took all patients presenting to their emergency departments over certain periods of time and looked to see which patients were actually hypoglycemic. And you can see the incidence here is certainly more common than the incidence of the disorders I showed you, but I think probably not as common as we sometimes associate, or in terms of how frequently kids get hypoglycemic when they get ill. You can see the incidents are quite different, and I think this goes to what the thresholds were that they were using to define hypoglycemia. They were certainly looking for more moderate to severe hypoglycemia, so I believe Cook Children's used a range of blood sugars less than 60, and University of Alabama may have used less than 40 or 45. So that probably explains why there's this discrepancy in the incidence. Cook's Children's took their study one step further. So they took all of the children that presented to the ED and were found to be hypoglycemic, which was about 160 patients, or 0.07% of the kids presenting to the ED. And they went and they looked into the charts and saw who actually then got a workup for hypoglycemia. And it was roughly about 50% of the kids. And of that 50%, 10% were diagnosed with what they termed a high-risk hypoglycemic disorder, such as hyperinsulinism or adrenal insufficiency. A low-risk hypoglycemic disorder was something like idiopathic ketotic hypoglycemia, something that was thought to the child would grow out of. So 10% of children with illness and hypoglycemia, about 10% of them will turn out to have a hypoglycemic disorder. CHOP did a study several years ago trying to look at this as well. What was the sort of risk of, or what was the likelihood of finding a low blood sugar disorder in children presenting with acute illness? So they looked at all patients that we received an endocrine consult on over the course of 5 years at CHOP. They pulled out the kids that presented with acute illness and ended up getting a workup for hypoglycemia. And so it was 45 patients with both an acute illness, hypoglycemia, who actually got a thorough workup with a critical sample obtained either in the ED or through a diagnostic fast. And somewhat similar to the data from Cook's Children, they found that 8% of those patients had a hypoglycemic disorder, with most common being hyperinsulinism or an underlying metabolic disorder. They were then able to look at were there certain features of the presentation that could predict if a patient would be diagnosed with a hypoglycemic disorder. And so what they found was younger age, a higher bicarbonate level, or not being ketotic. So a hypoketotic hypoglycemia was more predictive of you having a underlying hypoglycemic disorder. So as I mentioned, the differential for hypoglycemia is quite broad. I'm not going to go through this in any sort of detail. I just wanted to throw it out there. I'm going to take you through sort of these main groupings and then discuss a framework of how we kind of organize the differential of hypoglycemia based off of some initial lab results. So briefly, as I said, I'm just going to go through sort of the bigger groupings of hypoglycemia. So you have an understanding of the disorders that we're looking for. So the first being hyperinsulinism, which is the most common cause of persistent hypoglycemia in infants and children, which is why when we work up kids, this is one that we commonly find. It's due to dysregulated insulin secretion by the beta cell. So the beta cell is over-secreting insulin, but it also can have abnormal responses when children are given glucose. In some cases where they're given protein, there's even a rare form of it where exercise induces more insulin secretion and low sugars. And this is really characterized by a very severe and recurrent hypoglycemia, which is why this seems to carry the highest risk of developmental issues. It's broken down into 3 different types of hyperinsulinism, a type that we see most commonly, which is related to perinatal stress, which resolves within the first couple of months of life. There are congenital forms, which are due to genetic defects in the beta cells. This causes a more persistent hypoglycemia that frequently requires treatment throughout childhood. And then HI associated with syndromes, and the most commonly and most best described is Beckwith-Wiedemann syndrome. These children are typically born large for gestational age, as insulin is a growth factor in utero. So these babies often come out very large. Because of the severity of the hypoglycemia, they often have high GI requirements. Though it's important to remember that there's a clinical spectrum that exists to this, like with anything. And so we'll frequently have babies born with this that have normal birth weights and not quite such high requirements, and they can still turn out to have hyperinsulinism. Insulin blocks fat breakdown, and so you are unable to generate ketones. And so these patients present with a hypoketotic hypoglycemia. And since insulin is the main culprit here, if you give a child with hyperinsulinism glucagon, their blood sugar goes up quite rapidly because it's counteracting the effect of insulin. And then our treatment of HI, sadly, we do not have a lot of therapies for this disorder, which can make it challenging to treat. The only oral medication that's approved is diazoxide. Diazoxide causes excessive hair growth because it's actually a cousin of Rogaine. So this is a baby that got quite a bit of diazoxide. And for babies that can't tolerate or don't respond to diazoxide, we use a combination typically of somatostatin analogs and enteral dextrose. Some of these children do end up needing surgery on their pancreas. We try to reserve this surgery for children that have the focal form of HI, where just one part of the pancreas is involved, and we can do a partial pancreatectomy and cure them. For children where the whole pancreas is involved, diffuse HI, if we can't get a medical therapy to work for them and the HI is severe enough, we will actually have to remove most of their pancreas to be able to get them out of the hospital and keep them safe at home. In an older child presenting with evidence of excessive insulin in the blood, most commonly we find that they have an insulinoma, which is an islet cell tumor that overproduces insulin. There may be a family history of this, as insulinomas are associated with one of the endocrine tumor disorders, multiple endocrine neoplasia type 1. However, in any older child or toddler or older child that's been out of the hospital, coming back in with concerns for some sort of insulin-mediated process, we always want to keep in the back of the mind if it could be factitious hypoglycemia. So either because someone is giving them insulin, or we've had some accidental sulfonylurea ingestions as well too. It's not uncommon for us to see kids also present with hormone deficiencies as the cause of their hypoglycemia. So specifically deficiencies of cortisol and growth hormone can cause low blood sugars. with adrenal insufficiency, the hypoglycemia can occur with any of the forms, whether it's due to a primary issue with the adrenal gland or something at the level of the pituitary. Growth hormone deficiency does not cause hypoglycemia in older kids. This is only something that is seen in neonates, infants, and potentially toddlers. But in our older patients, in our school-age children, this is not something that we have to worry about. And then some children are born with brain, midline issues, structural issues to their pituitary, causing them multiple pituitary deficits. And they, especially as neonates and infants, will often have hypoglycemia. And for the hormone deficiencies, this causes a ketotic hypoglycemia. You're missing those key hormones that are helping the liver mobilize its glucose. And so you start breaking down fat sooner and making ketones. You should, at the time of diagnosis, have a low cortisol or growth hormone level, but it really is important to confirm the diagnosis by doing stimulation testing before starting a child on cortisol or growth hormone replacement. And then the treatment is very straightforward. We give children back the missing hormone, and that fixes the sugars. Glycogen storage disorders also present with hypoglycemia, and this is really a very large and heterogeneous group of disorders that are all due to having underlying problems in how glycogen is broken down, either in the liver or the muscle. As I previously mentioned, the ones that affect the muscle there is no risk of low blood sugars. It's only the ones that really affect the liver where you have a risk of low blood sugars. And so I've listed the ones that affect the liver here. And those would be the ones that we think about if we were suspicious for a child having low blood sugars due to a GSD. This also causes the ketotic hypoglycemia because you can't release the glucose that's in the liver, and so the body starts breaking down fat earlier. These kids classically have large livers because of the glycogen that's stored in there. The glycogen can impact the liver function, and so you have elevated LFTs. And something that I don't think is as appreciated as well is that this can cause failure to thrive, typically because these kids are not using the liver that's stored in the glucose. They're breaking down fat quicker. It causes weight gain and often poor linear weight issues, poor weight gain, and sometimes poor linear growth as well. And so children with this are either treated initially with just more frequent feeds, or when they eventually get old enough, we start them on cornstarch, uncooked cornstarch, which enables them to then fast overnight without becoming ketotic and hypoglycemic. Another category of disorders causing hypoglycemia is the disorders of gluconeogenesis. So gluconeogenesis is the liver's process to make glucose. And if you can't complete this process, it can obviously cause hypoglycemia. The most common of these is glycogen storage disease type 1, which is deficiency of glucose 6-phosphatase. And that is the final common step of both glycogen breakdown as well as gluconeogenesis. So you have pretty significant hypoglycemia because the liver really can't release glucose from either of its two common ways of having access to glucose. But this is combined with actually risk of severe lactic acidosis. So if you can't complete gluconeogenesis, the precursors back up into alternative pathways, and the byproduct of one of those alternative pathways is lactate. And so if these kids fast at all, they can develop not just severe hypoglycemia, but a really impressive lactic acidosis. To the point that we've actually had patients die of overwhelming lactic acidosis that we haven't been able to help them recover from. So really the treatment of this is these kids cannot fast at all. They really can't go longer than 3 to 4 hours without something in their system. So as babies, they're fed very frequently. And then we do try to transition them onto cornstarch that at least enables them not to feed as much overnight. I think important for for you to know, in case you were to see a patient with this, even an older patient that, say, presented to your emergency department, they really have to be placed on IV fluids right away if they're not able to tolerate PO. So even our older patients that are teenagers, adults, if they have a gastro, we don't try to manage it at home. We send them right to the emergency department to go on IV fluids, because their lactate levels will go up 3 to 4 hours without any sort of, if they don't have anything by mouth. The fatty acid oxidation disorders are another large group of disorders that can cause hypoglycemia. This is, again, a pretty heterogeneous group of disorders, and there's many of them. I think there's now over 30 of them described, and they're all due to defects in how the mitochondria do beta oxidation or fatty acid oxidation. There are effects beyond just the hypoglycemia. You can have involvement of the skeletal and cardiac muscle. The one that is the most common and the most well-known is MCAD deficiency. The diagnosis is a hypoketotic hypoglycemia, because it's the mitochondria doing beta oxidation that generates the ketones. So you cannot generate ketones. The vast majority of patients now with fatty acid oxidation disorders are thankfully picked up on newborn screening. So it's not common for us to find a child that has this outside of that period. And this is usually relatively straightforward to treat. You avoid any sort of prolonged fasting, and similar to the kids that have the disorders of gluconeogenesis, these patients often require dextrose containing fluids when they're sick or can't eat. And then finally, the last one to mention is this diagnosis of ketotic hypoglycemia or idiopathic ketotic hypoglycemia, which we do not think is really and truly a separate disorder or underlying disease. This we think of as more just a variant of normal, where particularly in toddlers, we see that they have this shortened fasting tolerance when we do fast them. And they seem to be prone to getting ketones and low blood sugars relatively easily by illness. This is something we also observe on kids that end up on a lot of continuous feeds or TPN, where when we do try to eventually have them fast, their body sort of doesn't know how to switch into fasting appropriately and end up with high ketones and low blood sugars. And so most of the kids that have this will present with a ketotic hypoglycemia. If we obtain a critical sample, if we do a fast on them, all of their metabolic results are normal. So no evidence of any other type of disorder. So our treatment for this is really just isn't very much. We typically tell families to not let their child fast too long, not let them, skip breakfast. And then a big guidance we give is when the child gets ill, they need to start checking blood sugar. So if they're so we could potentially avoid an admission or catch them early enough that maybe they can just get treated in the emergency department with some dextrose containing fluids. And then if we can get them eating, get them discharged. And in the vast, vast majority of cases, this just resolves on its own. Typically, by the time the child is starting kindergarten, these recurrent episodes have stopped. So that was a kind of a whirlwind tour of the differential for hypoglycemia. How do we see children with hypoglycemia present? In our younger children and our infants and toddlers, unfortunately, the symptoms of hypoglycemia are relatively nonspecific. and I've listed them there. So unfortunately, oftentimes, if we just go based off of symptoms, children either have these non-specific symptoms or they're asymptomatic. Being asymptomatic with pretty severe hypoglycemia is relatively common, particularly in our neonates and infants. And so the first presenting sign, unfortunately, for many of these kids, if they're not diagnosed right after birth, is going to be seizures. In our older children and teenagers, the ones that can communicate symptoms, we usually have it's usually easier to tease out for them to elicit symptoms for us. But as you can see, some of these are relatively non-specific as well too. We hope that we can catch kids before they present with severely altered mental status or seizures, but unfortunately, many of our children and teenagers come in that way as well too. With our older patients, we can rely on using Whipple's triad to help tease out if the symptoms are related to low blood sugar. So to take you back to medical school, Whipple's triad was originally developed to try to help identify patients with insulinomas, but it can be really used for any potential concern for low blood sugar. So a patient has signs or symptoms of low blood sugars. You actually document a low blood sugar that correlates with the symptoms, and then when you treat the low blood sugar, you have resolution of the symptoms. And I think this can help tease out, particularly with some of our teenagers, because some of their symptoms can be nonspecific, if these are truly related to low blood sugars, and how aggressive we need to be with the workup for them. So along those lines, which patients do we end up evaluating for low blood sugar disorders? So these are three groupings that I took from the Pediatric Endocrine Society guidelines from 2015 about how to evaluate and work up children for hypoglycemia. So in older children, we recommend working up those that demonstrate Whipple's triad. In infants and younger children who can't reliably report symptoms, we work up those that have documented blood sugars less than 60. And then the neonatal category is quite challenging, and so they recommend working up neonates that are identified as being at high risk of having a persistent hypoglycemic disorder. And there's a whole bunch of criteria trying to identify which neonates are at risk of persistent hypoglycemic disorders, and that could be a whole other separate talk. So what is our workup for kids that we suspect have a hypoglycemic disorder? So we want to be able to obtain what we call a critical sample, which is a blood sample and urine sample looking at the different hormones and metabolic fuels that are involved in glucose metabolism. And you really, unfortunately, need for these labs to help you. You need for the child to be hypoglycemic at the time to be able to see how the body is appropriately responding to the hypoglycemia. And so you can obtain a critical sample if the child is low in an emergency department. Sometimes it's not safe to be able to do that. You need to be able to treat them because they're altered from the low blood sugar. So in which case the safest way to do it is to admit them to the hospital, have them fast, do frequent blood sugar and ketone monitoring, and then be ready to obtain this critical sample as soon as the blood sugar goes less than 50. So these are actually this is actually the different sort of fasting durations that you can expect to see for healthy newborn infants, children, and teenagers. They seem quite long. And it's not that we always fast children this long, but there's good data that suggests that children can fast this long, at least without becoming significantly or severely hypoglycemic, and having an appropriate kind of rise in their ketones, which is the appropriate response to fasting. So when a child is fasting, what do we want to see as kind of a normal response? Obviously, as they're fasting and their blood sugars are dropping and they have a low blood sugar, they really shouldn't have any insulin in their blood. It should be undetectable. You want to be able to see elevations in their cortisol growth hormone. And then you want to see that they're generating both ketones and free fatty acids. Because that is the appropriate response. As your blood sugar is dropping, you should start breaking down fat, and you should be generating ketones and free fatty acids as another fuel that your brain can run on. And then your lactate level should remain normal. You should not have a high lactate level with a low blood sugar. That would suggest that there's some underlying issue with your liver if it's starting to generate lactate as your blood sugar is going low. And then this is the critical sample that we obtain at the time of hypoglycemia that really helps us start to sort out with that really broad differential what could be wrong with the child. And this is this framework that was developed at CHOP now probably 2 decades ago. To help sort into big buckets that broad differential based off of what some of these primary fuels do when the blood sugar is low. So as I mentioned, if you have a high lactate at the time of hypoglycemia, that's concerning for the liver not functioning correctly. So that would put you as a disorder of gluconeogenesis. If you have high ketones, this puts you into those disorders of ketotic hypoglycemia, so the glycogen storage disorders, your hormone deficiencies. And then if your ketones are low, you're either going to be dealing with a fatty acid oxidation disorder because there's issues with how the mitochondria is making the ketones, or you're dealing with an issue with too much insulin in the blood because insulin, as I had mentioned, is blocking fat breakdown, so you can't make ketones. So this has been a useful framework to put kids in a bucket and then use one of these 4 buckets and then use the critical sample to start narrowing down which of the disorders they could have in that bucket. So hopefully just in the last 5 to 10 minutes talking through our management of these children. So acute hypoglycemia management, we want to be able to get carbohydrates, dextrose into children as quickly and safely as possible to get their blood sugar up. And for the most part, as I mentioned, we do want to try to treat kids if their blood sugar is less than 70, though it's really more emergent once their blood sugar is getting closer to 50. So if the child is asymptomatic and able to eat by mouth, our go-to really should just be giving them oral carbohydrates. So this is the rare time where I advocate using juice because it's a really rapid acting carbohydrate that's going to get the blood sugar up quickly. Though increasingly it's hard to get kids to drink juice because they're not exposed to it. Basic like graham crackers or other simple carbohydrates also work well. Obviously, many of the kids are brought into the emergency department because they're altered or vomiting, and it's just not going to be safe to feed them. And so really trying to get an IV in them and giving them a dextrose bolus is the first thing that we recommend. In the endocrine world, we usually use a slightly lower volume dextrose bolus that is typically used. We usually recommend starting with a 2 ml per kilo dextrose bolus. It tends to still bring the blood sugar up nicely. You avoid some of the hypoglycemia, like the reactive hypoglycemia you can sometimes see with the bigger boluses. However, certainly if the child is not coming up with that smaller bolus, using your more typical 5 ml per kilo bolus is completely reasonable. If a child already has say enteral access, either an NG tube or a G tube, and they're not vomiting, that is really a great way to get dextrose into a child quickly. So oftentimes these patients are on dextrose 20%, but dextrose 10% works just as well to give a bolus through their G tube. And then if the child has an insulin-mediated process, glucagon is a great way to get their blood sugar up very quickly. So if they've HI or an insulinoma and you can't get access on them and they have a significant low blood sugar, 0.5 milligrams or 1 milligram of glucagon will get their blood sugar up very quickly. And then our team really recommends, unless you can kind of, unless there's other interventions that are being done that can get the child to eat, or something else that's going to reverse the hypoglycemia, we really recommend putting the child on a dextrose infusion. What we commonly see is a bolus is given, the blood sugar comes up, but the child is still not eating, or they're still sick, and they then have another low sugar. Because that bolus is only going to fix things transiently. It's not going to address whatever underlying issue is there. And so the child, not surprisingly, is going to have an additional low sugar. So either D5, or depending on the severity of the initial low, D10 at maintenance, until you can either get the child eating, or if there's concerns for a more persistent hypoglycemia process, some sort of more definitive treatment. And then for kids that are either already admitted or in the emergency department that are already on that IV or enteral dextrose, if they have lows, just starting with the feed or another bolus is helpful, but then also making increases to the dextrose infusions to avoid additional low sugars. So for the sort of ongoing management of these children, obviously you want to treat whatever is the underlying illness. Obviously, in a lot of these children, it's in the setting of illness and not eating or vomiting and diarrhea. And so once that resolves and is treated, that usually is enough to treat the blood sugars. And as frustrating as it is sometimes for families, we really do recommend trying to keep the IV dextrose on until we really think that they're in a good place and have taken some PO and are improving in their PO. Because otherwise what we see is if you try to wean off too quickly, they just have recurrent low sugars, and sometimes that can actually make them feel worse. And then I would also advocate for trying to monitor for a longer period of time off the fluids to just make sure that they truly aren't going to have recurrent hypoglycemia. Often, we hear, well, we had them off the fluids for 4 to 6 hours and they didn't have more low sugars. That's not entirely surprising because it's probably during the day and they're eating, and so their sugars are going to be fine. The question is what's going to happen to them overnight. So I think that overnight monitoring can give reassurance to the family that the child's truly going to be okay. It's also a good, a good way to screen for if there might be some more concern for a separate persistent hypoglycemia issue. And then who would we want to think about you guys either calling us for or referring to as an outpatient? Obviously kids where there is no preceding illness, or the preceding illness doesn't really match the severity of the low sugar. So if you have a kid coming in with a blood sugar in the 30s and 40s and they have just the sniffles, there's a big disconnect there. And I think that would be a kid that we might want to know about. And then obviously the kids that you can't wean off dextrose, or you're having to go up on the dextrose, particularly if they have, if they're eating again, that's definitely a red flag that something else might be going on. And then going back to that study from CHOP that I talked about, the kids that seem to be at higher, where it's more suggestive that they might have a potential hypoglycemic disorder, would be those that are presenting at a younger age, at less than a year old, or for kids that are not ketotic or acidotic at the time of hypoglycemia. Since what we have observed with illness is that the ability to generate ketones is still intact. You're still breaking down fat, you're still generating ketones. So if you're not doing that, and you're not then also becoming acidotic if you don't have the ketones, that's more concerning for potentially a separate hypoglycemic process going on. So our approach here when we get called on these kids is that we usually do recommend pretty frequent blood sugar checks where they're here to get us data. So before the kids eat, and then every 3 hours overnight. And then for those that practice here at certain points may know we usually do recommend doing what we call a safety fast overnight. So similar to what I was talking about with monitoring the blood sugars, for the kids that we see, we recommend an actual formal safety fast. So doing point of care sugars every 3 hours, ending the fast after 12 hours, or if the blood sugar goes less than 70, and then at the end of the fast, sending off a blood sugar and ketone levels if we can. And again, this is really twofold. One, to really make sure the kid is going to be safe when they're at home, that this illness has resolved to the point that they can go through the night with safe sugars without eating. But then also as a way to screen and make sure that we're not missing any patients that actually might have a more persistent blood sugar disorder. And many of these children, we do recommend sending home with the glucometer and to follow up with us. Not necessarily all, but many we will. And then when we see these children in follow-up, it's not that we bring all of them back in for diagnostic fast or put all of them through a lot of workup. The ones that we do additional testing for, primarily a diagnostic fast, is any child that we can't get to pass a safety fast in the hospital or get off IV dextrose. If the family is doing that glucose monitoring at home for us, if there's issues with hypoglycemia, particularly if they're well, those are kids that we'd want to work up. And then if they continue to have episodes, even with illness, we may recommend doing a workup just to make sure that we're not missing some underlying blood sugar problem. And then in terms of ongoing management for kids that we diagnose with, that we end up, say, diagnosing with a persistent hypoglycemic disorder, as I mentioned, we usually try to keep them on IV dextrose if we have a high suspicion that something else is going on, that there's a separate hypoglycemic disorder. We keep them on the IV dextrose until we can start a disease-specific treatment. So, for example, in HI, we would start with diazoxide. If we diagnosed a child with adrenal insufficiency, we would start hydrocortisone. All of our patients with hypoglycemia go home doing glucose monitoring to help us titrate therapy. Kids with hypoglycemic disorders, they inevitably have more low blood sugars when they get sick, even if they're well controlled when they're well. And so we really want families checking more with illness to catch issues early. And then increasingly we have requests for use of the continuous glucose monitors, those wearable devices that are used for children with diabetes. There's some definite limitations with how well they work for kids that don't have diabetes. And so our strong preference is to still use the glucose meters for kids with hypoglycemia, and then we reserve the continuous glucose monitor for kind of certain patient populations that we work with. And then just important guidance for families really is about that risk of worsening of the underlying hypoglycemia when they get ill, and sometimes having a low threshold for going to the emergency department. So back to these cases, this one case with a pretty significant illness that I think could explain the blood sugar and the ketones. This would probably not necessarily be a patient that I think we called about, and would probably be fine going on some dextrose and then having that weaned off after they were eating and drinking better. Our second case, on the other hand, one, it's a child that's younger, and while they're sick, what's described here would not necessarily correlate in my mind with necessarily the degree of hypoglycemia and ketosis that this child had. So this would be one that I would think about, really making sure they're going to be okay overnight off of fluids. If not doing a formal safety fast, at least observing them longer. And this would definitely be a kid that I think would benefit from going home with a meter and an appointment with us. So in conclusion, these are rare disorders, but as I hopefully pointed out, the consequences for children can be severe. Hypoglycemia with illness is pretty common, while hypoglycemic disorders are rare. Sometimes it's not uncommon for the hypoglycemia with illness to be the presenting sign of an underlying disorder. And so teasing those kids out and identifying them can be challenging. I would consider an endocrine consult or referral for kids that don't have ketones when they're hypoglycemic, when the hypoglycemia is out of proportion to the illness. And certainly for younger kids that are outside of that kind of classic idiopathic ketotic age range is also kids that we should probably know about. And then we really use fasting tests to guide the next steps. The diagnostic fast is really to understand if there's an underlying blood sugar disorder there and what it is. And these safety fasts are used to just make sure that kids will be okay at home, but also identify kids that might need additional workup.
Bueno, muchas gracias y a todos los que se conectaron los esperamos en nuestra próxima cápsula.